Today, we are going to talk about pleural effusion. Pleural effusion is the abnormal accumulation of fluid within the pleural space. The pleural space is a thin cavity between the parietal pleura and visceral pleura. The visceral pleura tightly adheres to the lung surface, and the parietal pleura lines the thoracic cavity's inner surface. The pleural space contains 0.1 to 0.3 milliliters of fluid per kilogram, which is serous, sterile, and clear. It lubricates the lungs and minimizes friction between the pleural layers during respiratory movement. The fluid is continuously produced by blood vessels in the parietal pleura, and is continuously reabsorbed via the lymphatics in the parietal pleura. Disturbances to this process lead to excessive accumulation of fluid within the pleural cavity. Normally, the fluid is regulated by a balance of hydrostatic pressure, oncotic pressure, and capillary membrane permeability. Hydrostatic pressure is the pressure that the fluid exerts on the wall of the blood vessels. Oncotic pressure is the force that draws fluid into the blood vessels, and capillary membrane permeability is how likely the capillary membrane is to let things seep through the membrane and move into the fluid. So, if regulation is out of balance, then we will have pleural effusion. This abnormal regulation happens because of increased hydrostatic pressure, decreased oncotic pressure, and an increase in capillary membrane permeability. Obstruction of lymphatic drainage can also cause pleural effusion. Pleural effusion can be two different types, transudate and exudate. Transudate pleural effusion occurs due to increased hydrostatic pressure, or reduced plasma oncotic pressure. Causes for transudate effusion include heart failure due to increased hydrostatic pressure, hypoalbuminemia, hypothyroidism, cirrhosis, nephrotic syndrome, etc. Exudate pleural effusion occurs due to inflammation and increased capillary permeability. This inflammation results in protein leaking out of the tissue into the pleural space. Causes include lung cancer, pulmonary infections such as pneumonia, and tuberculosis, inflammatory disorders such as rheumatoid arthritis, gout, bronchitis, trauma, etc. Leitz criteria are used to differentiate between exudate and transudate pleural effusion. An exudative effusion is diagnosed if one or more of the following criteria are met: pleural fluid protein to serum protein ratio more than 0.5, pleural fluid LDH to serum LDH ratio more than 0.6, or pleural fluid LDH more than 2/3 of the upper limit of the normal serum LDH value. If none of these criteria are met, the fluid is considered transudate. Signs and symptoms of pleural effusion depend on its size. Small effusions with fluid less than 300 milliliters often show no significant clinical findings. If fluid is over 300 milliliters, signs and symptoms can be seen. The amount of effusion correlates with the severity of symptoms. Because the effusion takes up space in the chest, and makes it more difficult for the lungs to fill with air, so, the patient will present with shortness of breath. The patient might have cough, due to diaphragmatic irritation. If the patient has active pleural inflammation, called pleurisy, they can have pleuritic chest pain, which is sharp, severe, localized pain with breathing and coughing. This pleuritic pain tends to subside when an effusion develops. Also, there will be dullness when we percuss over the area of the effusion, because there is no air to transmit the sound. On auscultation, there will be decreased breath sounds, tactile fremitus, and vocal resonance due to reduced air entry. There will also be asymmetrical chest expansion. In massive effusion, there will be mediastinal and tracheal shift away from the effusion, so we will find tracheal deviation. Diagnosis. Chest radiograph is an excellent initial imaging tool to identify pleural effusion. In X-ray, we can see blunting of the costophrenic angle on a postero-anterior, erect radiograph. If there is a massive, large effusion, the meniscus sign can be seen. Meniscus sign means blunting of the costophrenic and cardiophrenic angles. Also, There is tracheal and mediastinal deviation, away from the effusion.
Ultrasound scan, CT scan, and thoracentesis also can be used for diagnosis. In thoracentesis, a sample of pleural fluid is taken using a needle and analyzed for protein count, cell count, pH, glucose, LDH, etc.
Treatment. If there is a small pleural effusion, then conservative management may be appropriate. Management primarily focuses on identifying and treating the underlying cause of pleural effusion. For example, in pneumonia we can give antibiotics. In congestive heart failure we can give diuretics. If there is a large effusion, it often leads to aspiration and drainage. But if the effusion relieved by aspiration reoccurs, repeated aspiration may be required. Complications. Due to fluid accumulation within the pleural cavity, the lung can be compressed, and this compressed lung can cause respiratory compromise. So, patient have symptoms like shortness of breath, fast breathing, or taking lots of rapid, shallow breaths, blue fingernails or blue tone to the skin or lips, and extreme tiredness. The accumulated fluid can get infected, and can cause empyema. Therapeutic interventions such as intercostal tube insertion can cause pneumothorax. And also, repeated effusion episodes followed by chronic inflammation leading to pleural thickening from fibrous adhesions.